Assalamu alaikum. We are doing a left-sided nephrectomy for a non-functioning kidney which has proximal ureteric stone, and we are dealing with the pedicle. Here you can see that there is a major vein here. So we are dissecting this vein and we are trying to find the artery. But after a lot of effort, we were not able to find the artery. So we completely dissected the vein. Here you can see that there is some tissue behind the vein, which upon the suction dissection turns out to be some white color, and we thought that this might be the artery, as on the CT scan the artery was superior to the vein. So we thought this was the artery, and we were happy. So we kept on dissecting and this white structure, and upon further dissection we came to know that this actually is the major renal vein. It is not the artery. So after finding this vein, we dissected and looked for the artery here and there, but actually we were not able to find the artery. So finding the second vein gave us courage to clip and divide the first vein, because we think that there will be no congestion, as there is a vein and a major vein to drain the kidney. So there is no fear of congestion. So after dealing that, now you can see that the hilum is quite wide open to us now, and we are dissecting and trying to find the artery above the vein. However, upon some dissection, we still were not really able to find the artery clearly, and so we tried to look behind the vein if the artery can be approached posterior to the vein along its upper border. We found a tubular structure, and we thought that this might be the artery for this fibrotic and chronically inflamed kidney. But upon dissection of the tissue around that tubular structure, we found that this is a tributary of the renal vein, and it is not a renal artery. As you can see here, the structures and the fibers posterior to the renal vein are being dissected and then coagulated and divided by the ligashore. So here we found that there is a confluence of this tubular structure to the main vein. So we left that place again, and we continued our dissection on the superior border of the vein, and there we found that there was a structure. The reason for difficulty in identification of the renal artery, especially in such kidneys where there is a stone in the PUJ, or there is a stone in the proximal ureter, or there is a stone, for that matter, in the renal pelvis, and the kidney is rendered non-functioning, it means a prolonged process of repeated infections and inflammation, and by the end this infection and the inflammation, they end up in fibrosis, leading to the fibrosis of the lymphatic tissues around the artery, which makes the identification of the renal artery and its dissection difficult. So after completely dissecting the artery all around, we made a window which was just enough to clip the vein, with the plan that further dissection of the artery will be made after the vein has been clipped and divided. In order to get more length of the vein, to apply 2 clips proximally and 1 clip distally, and then divide the vein in between these clips, we need to have more length of the vein. So we kept on dissecting the proximal and the distal portions of the vein, and now you can see that dissection of the renal vein is also complete, and we have a length which is enough for application of the hemalock clips. So we apply another clip distally, and the second clip is applied in between, and then we divide the renal vein, leaving a sufficient stump on the proximal side. Sometimes the scissor can be really blunt, so it takes little time. And then to complete the dissection and division of the hilum, the rest of the artery is being dissected to achieve length, so that clips can be applied easily proximally and distally, and then the artery can be easily divided. So the length is now enough, and we are applying the clips, and then we will divide it. Thank you very much for watching.